Okay, let's get started. So welcome to the Substance Use and Addiction Lunch and Learn webinar series. My name is Liz Yu. I'm the Partnership Manager with UBC Health and the BC CSU. This series is hosted by UBC Health and BC CSU, and it's on, this webinar, this session. And today we are going to be learning about opioid use disorder and treatment options. Today's session is also actually a special one, which is hosted in partnership with CRISM, the Canadian Research Initiative in Substance Misuse. I'm joining today from the unceded traditional territories of the Musqueam, Squamish, and Tsleil-Waututh Nations, and I acknowledge that the ongoing criminalization, institutionalization, and discrimination against people who use drugs disproportionately harms Indigenous peoples. I'm just going to go over some housekeeping, and while I do that, I'll just pop over to the learning objectives as well. So before we begin, I just want to say that this webinar is being recorded. All attendees are automatically muted. However, feel free to type in the chat box, and if you have any questions, please use the Q&A function, and we'll get to those at the end of the discussion. We have a short post-webinar survey. So if at the end you could take 2 minutes to fill that out and let us know what you thought, it'll be really helpful for us as we continue to develop these learning opportunities for you all. We have an amazing panel here today. And so without further ado, I'll pass it on to my colleague, Lizzie Matzinger from Changemark Research and Evaluation to start us off.
Hi, everyone. It's so nice to see so many faces, or not so many faces, but all the panelists. My name is Lizzie Matzinger. I'm a knowledge mobilization consultant with Changemark Research and Evaluation, and I'm working right now with CRISM to move substance use research into action. I'd like to acknowledge that I work and play on the unceded and unsurrendered territories of the Anishinaabe and Algonquin peoples who have cared for and stewarded these beautiful lands long before we've been here. And these are colonially known now as Petawawa. Just a tidbit, so translated roughly from Algonquin language, Petawawa means where one hears the noise of the water. And this was a place where people would gather to socialize and to trade. And so I'd like to bring and share this spirit today of gathering and exchanging thoughts and knowledge around a really, really important topic of opioid use and opioid use disorder, which disproportionately and inequitably affects Indigenous communities across Turtle Island. We have an amazing group of folks that are joining us today to share their knowledge and experience. So I'm going to actually turn things over and call on each of the panelists to introduce themselves, their role, and why their motivation, why they're here today. So let's go to Ainsley first.
Hi there. Hi, everybody. My name is Ainsley, and I am coming today to you from the unceded Musqueam territories, otherwise known as Richmond in British Columbia. And I, really briefly about myself, oh yeah, you can actually see my shirt there. Nice people take drugs, and on the back it says drugs take nice people. So just acknowledging that we are still in a crisis state with drug poisoning, overdoses, and I really do think it is a toxic drug and bad policy reason why we are in this state right now. I'm coming to you from my lovely Vancouver Coastal Health Office at the Anne Vogel Clinic, which is Richmond's only opioid use disorder clinic. And I am a social worker by training and background, and my title here is concurrent disorders clinician. But I try to do a lot of things while I'm here and just help people wherever they're at. So really happy to be here. Thanks for the invitation, and I look forward to the discussion. Am I meant to pass it on, or Lizzie, do you want to pass it on?
I can pass it on. Go for it.
Okay, I'll pass it on. Where's Mona? There, I'm going to go to you, Mona.
Here, thank you. My name is Mona. I work with the BCCSU as their director of one of their pharmacy stream programs, or the interdisciplinary fellowship program, also the pharmacy advisor with them. Traditionally, I've always worked and played in Squamish territories and Musqueam and Tsleil-Waututh First Nations. Today, I'm actually joining you from Anishinaabe and Haudenosaunee Nation right now, over here in Kingston, just with my teammates here doing different work in this little room here. Happy to be here because I really want to share some of my knowledge and learn from each other. Been working with Dean and Supreet and Ainsley for a while over the years as well, and just sharing a lot of information, especially with Liz and then now Lizzie. Nice to see you guys.
Thanks, Mona. All right, Dean.
Hi, I'm Dean Wilson. I'm the peer lead at the British Columbia Center for Substance Use, and I also do community liaison for the Portland Hotel Society. I've been a harm reduction from a way back. I'm the guy who sued the government to legalize and constitutionalize supervised injection sites. I'd like to recognize all the nations that are represented in the downtown east side who come to live, but mainly die. I'll pass it on to who's next. Oh, it's Supreet. Hey, buddy, I haven't seen you for a while. Anyways.
Hi, everyone. I'm calling from Vancouver, so the unceded territories of the Tsleil-Waututh, Musqueam, and Squamish nations. I am an addiction medicine physician. I've been fortunate enough to work with everyone who's on this call. I'm based at St. Paul's. I'm one of the addiction medicine physicians here, and I'm the medical lead for the Rapid Access Addiction Medicine Clinic, which is based at St. Paul's as well.
Great. Thanks, Supreet. All right. So how this is going to work, we have 3 questions with some sub-questions all around opioid use and opioid use disorder. It's going to be a free-flowing conversation. I'll probably call on each of the panelists at some point or another to start us off. But please, panelists, feel free to jump in, either use the raise your hand function or raise your literal hand if you'd like me to turn things over to you. Audience, please use the Q&A function to submit your questions. That's what we're going to be monitoring throughout. We've saved 15 minutes at the end to go through those, so sit tight because we might actually address your question as we're going through, okay? All right, so I'm starting actually with the hardest question, which is what is opioid use and opioid use disorder? And Ainsley, I'm going to call on you first to take this one, and then I see Dean kind of grinning, so I'll probably go to him after.
Oh, geez. Yeah. So opioid use disorder. I mean, it's in the DSM, right? So it's in the Diagnostic Statistical Manual, DSM-5. It's under substance use disorders. And I mean, I don't really go all out with the DSM, but in order for someone to be diagnosed with opioid use disorder, there must be kind of an unmanageable use of opioids that is taking over people's time and functioning and ability to cope with their life and their daily tasks and activities of daily living. So I feel what I'm seeing here, and I'll pass it over to you in a sec there, Dean, but there really is a tension at my clinic anyways these days between pain and pain disorders and then opioid use disorders. And personally, I think there's a lot of overlap there. People have, as we've seen through documentaries in the news, people have become physically dependent on opioids through pharmaceuticals, and then they might be cut off, and then they go to street level supplies. And it might have been originally for pain due to injuries or surgeries or some kind of physical pain. But then people's lives often do become kind of chaotic and unmanageable when they need more opioids than they can get legally, right? And so then we get, I don't think we're going to go down the rabbit hole of criminalization and decriminalization and whatnot, but I do think that there is a spectrum within kind of pain disorders and opioid use disorders, and we have to, I think we have to treat everything and everyone with compassion. But yeah, I'll pass it over to you, Dean, to further elaborate.
Okay, to the audience, I was a heroin addict for the last 55 years. Presently got the first 6.5 months straight in my life in the past 6.5 months. But to me, opioid disorder is when the drugs start actually taking the negative effects in your life. You know, I've known lots of people who've done opiates on a night when they're feeling crappy. The next day, they still drive their kids to soccer. They don't use it again. You know, the pain thing is another whole thing. You know, you can get caught up with that stuff when you get started with pain. So that's another one we just got to make sure that we're on top of. And doctors, and that means doctors and patients have to have a really good relationship. And but it's when you start becoming, you know, the whole life becomes revolving around the drug. You know, I went from, you know, using a bit of it to, you know, being street entrenched, and, you know, I was no poser. You know, it was every 3-4 hours around the clock for 45, 50 years. So, you know, it's a hell of a life, and it's a really shitty life. But that, as I say, I think it's in degrees. There's a bit of a hierarchy here, and we should address that hierarchy, and we should try to intervene at the lowest parts of that hierarchy. So anyways, it's when negative behaviors really start setting in, but with the use of any drug, let alone opiates. But opiates have that significant fact that they you know, they have that with physical withdrawal that unlike anything else, plus the mental effect that all the other drugs have. So I don't know, Mona or Sapri, who wants to go?
Oh, Sabri, go ahead.
Yeah, I think, you know, when we're thinking about substance use, I think it's like that point that Dean was making was really important. When we think about any use disorder, we're really thinking about sort of the medical term for addiction, which is maybe the more common thing that we relate to. But for any substance, the vast majority of people who are using any particular substance, and whether it be alcohol or an opioid like heroin or fentanyl, the majority of people who use that substance don't have the sort of features or the diagnostic criteria or the effects that we would say define addiction. So like substance use does not equate to substance use disorder, and for really any category of substance that's true. And then when you think about what separates what we would think of as just use, so like having a drink or using an opioid from a use disorder, are some of those sort of cardinal features, and we often over medicalize it. But when we do, we think about the broad effects on a person's life. How is it affecting their relationships? How is it affecting their physical health? We think about whether they have cravings or desire to use a substance that is sort of uncontrollable. We think about how that use maybe goes beyond their element of control. So when someone has control over their substance use, that's good, but we know that substances can sort of take over the brain or manipulate the brain in ways that control is lost. And then we think about also how what people's goals are in terms of do they want to still be using. You'll hear people say that at some point they wanted to be using but they no longer are, and so that's another element of sort of control that's lost. So really it's a disorder that you can define broadly as sort of a loss of control and the consequences as a result of a substance. As Ainsley sort of pointed out, it's there's often, not always, but there's often things that either started someone using or keeps them using. And so that's where addiction gets really complex. As much as we can define it sort of simply and put sort of these labels on it and use the DSM, we know that substance use in general is very complex. Why would people use substances is extremely different from person to person. And we have to think about those things when we're thinking about how to treat it. We have to think about where are those underlying drivers, what are those underlying social stressors, what are those underlying, if you think about like a housing crisis or depression or pain, those are all things that are very differently addressed, but it can actually lead to the same use pattern.
Great. Thanks, Sapri. Mona, is there anything you wanted to add there?
No, I think we can talk a little bit about substances that you can use to help the opioid use disorder as well. And I'll just get Liz to put up something for me to walk through.
Yes, that kind of goes to our next question, which is what are the treatment options that are available? So yeah, I'm going to turn.
Yeah, so Dean and Supreet were talking about different substances that individuals are taking right now, and there's treatment options available. And when you look back at substance use disorder and you're thinking, all you think about because of the media is really methadone and then downtown east side, all those pictures. But That being said, I mean, methadone's been in the area since forever. And originally it was for pain. Way back, it's still used for pain. So this is a difference between methadone and some of the other substances that I might be talking about now. On the left-hand side, you see it in orange tang. Right-hand side, it's just another formulation that's red. So I give it an example, just like Cheerios, right? There's different types of Cheerios out there. And these are replacement therapies that can help the individual cravings depending on what they are used to taking. So this is methadone in general. I'll get you to the next slide. So in terms of agonist therapy, so you'll hear about methadone that people are taking originally now, and then there's buprenorphine naloxone, which is in the middle there. And that is another form of therapy. On the right-hand side, you will see that there's oral morphine, and I'll just give you an idea of what things look like. So it goes from anywhere from low intensity, meaning a lower intensity treatment form, to high intensity, meaning a person can use oral morphine a bit later on, and it can go back and forth, and many different people do go back and forth on the therapies. So next slide, please. Some people have asked, especially in the audience, like, what exactly is Suboxone or buprenorphine naloxone? What does it look like? It looks like any regular pill, just like diabetes medications, etc. This is a once-a-day therapy, and people might take it orally in the form of a tablet. There's some sublingual films that go on the side, so that's just a different formulation that you might see or hear about in different countries. So I just wanted to give you an idea of what the drugs look like. So next slide, please. So this is a new formula where you've heard of injectable formulas. This is buprenorphine extended release injection. What's great about this medication for some people who might not want to take a medication daily, it's a once a month injection. So as you are aware, like with diabetes, asthma, there's always new things coming out. This was a new formulation that came out not too long ago. So there's always inventions about different formulations for medications. Next slide. This is an example of long-acting capsules. Like, what does that mean? And then you can see on the left-hand side, that's a Cadian capsule. There's a little dots in there. For those of you that are as old as me, you remember Contact C. So Contact C are little pellets that you take, and it's a 24-hour release formula. So it looks like the size of like an antibiotic, really small. On the right-hand side, MS-LAN, that's another type of morphine formulation. And these beads are actually tinier. If you look at it very closely, it's just a 12-hour release formula because it's very different. Very similar to cold medications out there. Some are longer release and some are shorter release. Next slide, please. The higher intensity medications, you might see it, some people mention that there are injectable medications. And this is an example of a hydromorphone injection that some people may take depending on the level of medications that they might need for the opioid use disorder. So I wanted to just give you a bit of a highlight of what things look like so that you're aware. And Supreet.
Yeah, so what Mona is really talking about are really, medications. When we think about, I guess, any disorder or any diagnosis, we think about how we treat it, and the mainstay or one of the main components of treatment for an opioid use disorder are long-acting sort of replacement therapies or opioid agonist therapy, as they're sort of termed. The main role there is really to address some of the physical symptoms that emerge after someone is using a substance for a long period of time and develops physical dependence to that substance. The main sort of rationale behind all of these therapies is that they are extremely long acting, and so we know that when people are using a substance for a long period of time, that they become physically dependent on it, they have withdrawal symptoms, and they stop using. So there's sort of two functions that that methadone is trying to serve, or these other agonist therapies are trying to serve. One is to remove or try to address some of the withdrawal symptoms, but do so in a way that doesn't necessarily cause the euphoria or sedation that may come along from using another substance. We know, though, that as there at one side sort of pointed out, that as in the same way that we are and have to say that opioid use and opioid disorder is complex, the treatment also is complex complex in the sense that these medications are one piece of it, but they are by no means a sort of complete treatment of opioid use disorder.
That's great. Thanks, Sabrina. And I think that really ties nicely. And Dean, I'm just about to call on you to chat about, how that ties into harm reduction. I don't know if that's what you were.
Well, I wanted to talk about what Mona said. Like, I advocate for, even prescription of diacetyl morphine, heroin, all right to that spectrum. But I'm a realist too, and I realize that that's not going to be happening in the rural areas. But all those medications that Mona's talking can be done through a pharmacy, and every town has a pharmacy. So these are very good access points to get on kind of treatment. And I don't shut the door on anything. If you can get out through abstinence, get out. But if you need help in other ways and a little longer strategy, that's also good. But the things that Mona was bringing up can all be done in small towns also. So that's what's so good about those. We're not going to get prescription heroin in some little town. I don't think in my lifetime, but these other are applicable. So, but getting to methadone saved my life. I'm still on it. I've come down from 190 down. I'm down to 80 right now. Hopefully this journey I'm on right now is going to result in me being off methadone completely by 1924. And I'm just really happy that it has allowed me to just have a normal life. And what's wrong with that? So we've got to address all the, I like what Sapri said, like every addiction is as individual as that person. And so you can't say that, oh, that's going to work for everybody. It's not like that. So, as long as we have a lot of things in our toolkit, methadone, we have, we have bupe, Suboxone, we have diacetyl morphine, heroin, morphine. Let's have all of them in our toolkit and let's apply them when they're needed. If you have somebody like myself who was street entrenched for maybe 40 years, I tell you, buprenorphine is not going to be my first choice. But we've done a lot of work around this. I've worked with all these people for a long time to come down to solutions that I feel are actually working. The toxic drug supply is a whole different thing. Until we get them on treatment, we can't stop that. But the people that are on this panel I've worked with them for a long time to make sure that we're as safe as possible. So good on them all too.
Thanks, Dean. Ainsley?
Yeah, I just wanted to also mention, I think sometimes it sounds a little bit cut and dry, and I really think we are getting to the nuances about how each person needs an individual plan of treatment. And I see that here in our clinic. I don't know if any two people are on the exact same formulation of treatment, and there could be such different combinations of different treatments and whatnot. But I also just want to acknowledge that it's, the fact that a lot of folks are polysubstance users, and that there is so many other things in the substances that are out there right now. A lot of opioid users, or people who use opioids, are taking fentanyl by choice and carfentanil. And then we have the benzos that are in there as well. And so we're usually not just treating one kind of substance use disorder when we say even opioid use disorder, because people are using many different kinds. I do feel fortunate that under the umbrella of opioid use disorder, there are quite a few options, whereas for other things, such as stimulants and even alcohol, there just aren't as many options for treatment. And but yeah, we really need to be looking at a wide range and have providers that are comfortable providing and prescribing a wide range of things, because what works for one person is not necessarily going to work for another person. And just wanted to bring that up.
Thanks, Ainsley. Mona?
It's exactly what Ainsley was saying. Everybody is different, and it doesn't have to be the same over again. You can be shifting different things, and the key thing is communications, right? Communications with different providers, with your pharmacists even, to just walk through, and if there's questions, because oftentimes there's questions. If you start a new medication of any type, or if you were on a medication for a long time, you have questions. So it's really good to continually engage in this.
Thanks, Mona. I'm going to move us along, but it is related on a similar vein, which is, and I'm going to merge these two questions together, which is, how are these treatment options typically delivered? So whether it's frequency, location, I think that might be helpful for folks to know, what does it typically look like the day-to-day for someone that is receiving one of these treatments? And then maybe also, what are some of the key considerations that clinicians and patients have to take into account when they're determining treatment options? And I know all of you sort of touched on this and how it's individualized, but maybe a bit more specific as to what some of those conversations look like, or maybe should look like, between clients and providers. So who wants to go first with that? Okay, Dean.
Okay, I'm unmuted here. Where are we? I just spaced it. What are we going again? Maybe so.
How is treatment delivered?
Oh yeah. Okay. So look,
yeah.
I go get my methadone daily, and now I've got caries since I've straightened out. But I used to have to go daily, and we all bitched about it forever. And it was really funny. COVID came along, and all of a sudden everybody got caries. And my doctor said that only 2 people took her up on it, that we still came out daily to do it because it had become part of our lives. So I think that's a funny little story. And for me, many times, because I think I've used drugs in my life because of my depression, I would leave the house if it wasn't for me having to go get my juice. So in many ways, it was beneficial to me. But people bitch about it, and it is it's strangling for those that can't live like I do, a block away from my pharmacy. You know what I mean? Some people have to hitchhike 2.5 miles every day to get their methadone. Buprenorphine's a different thing, where they can start taking caries. I think it is after 2 weeks of stabilization, as opposed to a minimum 3 months on methadone. But I've never seen anybody get take homes after 3 months in the methadone game. So that's a fallacy. But it all depends on how you look at it. Like, people who are using this just to continue their treatment, to continue their drug use, but are trying to just be safe, that's, they don't like being strangled by all the restrictions in that. Others who will do anything to get out from where we're at hate it, but they do it. And then it becomes part of their lives. And like anything that's part of your lives, it's part of your lives. But as I say, we like to bitch about lots of things. And so we bitch about it. But I say, some places, it's as an individual. If we see somebody it takes a huge part of their day to come and get that once a day, then it's only logical that we soften those regulations. If somebody lives a block away and is still suffering badly, then yeah, we want to talk to you daily. We want to look to see, how are you doing? And I think it's a perfect access point where we can have all other kinds of supports. Like, you can do a lot through a methadone doctor's visit, and you can do a lot through a visit to a methadone clinic every day, as long as they're a legit place. So I know a lot of my fellow users will be a little mad at me for now. They'll say, we don't want all those rules and regulations. But look, I've been doing this for 40 years. And as I say, sometimes I really need those supports. And I'm the type of guy who's never going to ask for them. I'll tell you that. I'm not going to ask. And yet, if somebody reaches out through my individual daily visits, that's a real bonus to me. So I give it up to a lot of these pharmacists who actually take a lot more recognition of our illness than people give them credit for. So, and we have a daily relationship with our pharmacists as opposed to our doctors. And so they become very, very heavy relationships, whether they're good or bad.
That's great. Thanks, Dean. And I'll just add for folks, caries is take-home doses. It means you don't have to go every day. So just like another prescription that you would get for whatever it is in a bottle, you might be able to take like a week's worth home, or it depends on the medication, but just so folks know, that's what caries is. Supreet.
Yeah, just to build on what Dean was saying, I think in some ways we're lucky in this province, or in this country, even in the sense that opioid agonist therapy, including methadone, is treated like other medications, in the sense that it's dispensed through community pharmacies. So our neighbors down south actually don't have that sort of advantage. There largely are sort of dispensing centers or locations where a person has to go, where the medication is sort of treated extremely different compared to their blood pressure, diabetes medication. So we're lucky in that sense. But I think we also have to recognize that availability of opioid agonist therapy is still very much concentrated in urban centers, that the rural access to addictions care in general is much more limited. But even in these urban centers in Vancouver, it's not, I think, that difficult in comparison to other places to get a methadone. But I think it still needs to recognize that the sort of treatment of addiction still comes with a lot of stigma, and it still carries a sort of a fair bit of regulatory red tape that doesn't necessarily apply to other medications. And some of that stems from, the fact that these can be dangerous medications, but some of these are historical sort of anomalies that are perpetuated sort of unnecessarily. So you still have a fair bit of regulation around sort of training required to prescribe medications, which unfortunately translates to there being often not that many providers who are actually providing opioid agonist therapy or prescribing it. In an ideal world, you would see a prescriber and receive all your medications for your various conditions. But we know that this is often treated as a very sort of specialized area, despite the fact that in terms of rigor or sort of complexity, it really isn't. And with the prescribing aspect of it, there are also a fair bit of regulations around how methadone or other forms of opioid agonist therapy are prescribed, and that typically they're started on a daily dispense or daily witnessed ingestion sort of regulation, and that over time, if a person is absent from prescribed substances or non-prescribed substances, that the sort of transition to those take-home and carry doses people were mentioning. And sure, there's some aspect of regularity that may be beneficial, but we also know that comes with an incredible amount of stigma of having to go to a pharmacy and essentially, ingest this medication on a daily basis. That comes with people not wanting to access certain types of care because of the sort of the hoops they need to jump through and the particular providers they need to go through, and the amount of time it takes for what really should be a fairly simple sort of treatment of their condition. And unfortunately, the way that this, I think, most problematically presents is that you have the people who are most, facing difficulty and experiencing detrimental effects in their lives, who are now being presented with a potential treatment that comes with, lots of extra work that needs to come through. And often it's in those situations they're feeling the worst that they are unable to sort of deal with that. And so we have lots of issues with these medications in terms of retention on treatment, discontinuation, access in general, and particularly in underserved areas.
Great, thanks, Supreet. Anyone else want to add to that?
I guess I'll just quickly say, in case the question was also like, how often do people need, like it's quite an engaged process with your provider. There does need to be, especially when you're getting on a medication, quite frequent visits to see the doctor, unless of course you're in a hospital setting where they can do a quick titration up. But if it is in community, it does, can take a number of weeks or months, depending on what form of OAT people are put on and what the treatment plan is. But, once people are stabilized and have been kind of stabilized on a treatment for a long time, they can go once every 3 months, but a lot of folks have to go every couple of weeks, right? And then if they start, there's also, I just want to mention, and maybe Monique could speak more to it, but if you do miss a day or 2 or 3 of your medication, then you have to start again. And that is so frustrating for so many people. I think, is Cadian 2 missed doses? Oh, I might be able to talk. And methadone.
I can speak to this and how to prevent these things in terms of some of the care processes that change.
I'll just say it is. I see it a lot, and it is. It's a real barrier for a lot of people who just have other things going on in their lives, and if they do miss doses of having to go to the pharmacy, that can really destabilize people. And as we all know, there are lots of things happening in our busy lives, and we might miss something here and there, but there can be really big impacts and consequences if you miss a couple concurrent doses of your OAT, and that can really impact people. Thanks for the thumbs up, Dean.
That's a great point, Ainsley. The missed doses is a huge barrier. And before we jump more into barriers, I just want to circle back quickly, and because I'm seeing a little bit in the chat too, which is, what does the process look like when clinicians are deciding, somebody comes in and says, I want to get on an opioid agonist treatment. So what does that conversation look like in terms of determining which ones? We don't have to get super granular with it, but I think it would be helpful for the audience to get a bit of a sense, as to what factors go into that decision making, who determines it, and what those conversations look like. So maybe I will turn that over to Supreet or Mona.
I think from a pharmacy perspective, I'll roll it back a little bit first, is if individuals come in to pharmacy, we're lucky because I'm in an urban center, so I know exactly where to send an individual for help. Some virtual clinics have popped up, which is also very helpful. I know healthcare systems are changing over time. From my angle in a pharmacy, I actually call these places to give them a heads up, just because I want to make it easier. The person is waiting, wanting to do it right then and now. And that is so important to make it easier for that individual to go to get to a clinic or a clinician. At the pharmacy level, I can't do much at this time, but that's what I do. And I think Supreet's probably had a few of my calls saying, sending this person over.
Thanks, Mona.
Yeah, I mean, broadly, if you're thinking about let's say methadone, buprenorphine. I mean, the first sort of decision, if someone is felt to sort of need opioid agonist therapy, really is just to describe, I think, quite frankly, what the sort of prescription phase of being on these medications looks like, where the regulations around buprenorphine, so Suboxone, are fairly permissive in terms of carry doses, and what that sort of looks like is one sort of description and potential factor. The other sort of main differences really relate to what the titration and initiation phase look like. So buprenorphine, because of its sort of pharmacology, is a bit difficult to initiate. So there are some considerations where a person needs to be in withdrawal prior to administering a dose, unless we use some sort of alternative dosing strategies. But all that to say that initiating buprenorphine can be more complex than initiating methadone, but it can be something that reaches a therapeutic dose in a quicker period of time. So just broadly sort of saying that we need to think about whether a patient in their particular situation in that moment is able to tolerate that initiation process in a way that allows them to start buprenorphine, or whether methadone might be a more appropriate medication. Another sort of major difference between, if we consider methadone and Cadian to be full agonists and then a full opioid agonist and considered to be fairly similar drugs, buprenorphine at therapeutic doses can block the opioid receptors and block the effects of other opioids that are used. So for some people, depending on what their goals are, buprenorphine can be a bit of a tricky medication in the sense that it can prevent the sort of effects of ongoing fentanyl or heroin or whatever use. And so while that may be advantageous, it also may be unrealistic for a person, in which case they may not be particularly keen to use buprenorphine. And then I think the main other sort of differentiating factor in terms of what you're going to initiate is what's been trialed before and what's been effective before. People unfortunately often destabilize off these medications, and often are treatment experienced when we see them, in the sense that they have feelings or thoughts or experiences that they can relate back to, and then help us decide which medication is appropriate. In general, we would consider buprenorphine or Suboxone to be the first line medication, but I really sort of struggle to say that it's truly first line. I think methadone and buprenorphine are both tried and true medications that are sort of 1A and 1B, and those are the medications that we try for people. I see in sort of the chat there's a question around whether for fentanyl use that people may not feel well, even though they're sort of in the appropriate setting to initiate buprenorphine. I think the question of how fentanyl and how other more potent synthetic opioids affect the brain and affect buprenorphine's efficacy are sort of unanswered. I think we have some treatment strategies in terms of, higher doses or reevaluating when a person is appropriate to initiate buprenorphine that have helped us utilize those medications. I think that ultimately, just like any other medication, there's going to be some people who don't, tolerate or do well on a medication, in which case, after a period of time, if you've given it a, good shot, then I think you can say, let's try something else. I don't think I can say sort of across the board that for people who are using fentanyl, that methadone is better. I think there's lots of patients who do really well on buprenorphine who are using even very high degrees of, or like high quantities of fentanyl. But I think that it's worth noting that we have seen some sort of changes in the tolerability and efficacy of buprenorphine since fentanyl replaced heroin as the primary unregulated opioid.
Great, thanks, Supreet. I'm just looking at the time now, and I want to leave 10 minutes or so for questions. So what I'm going to loop back to is really the barriers, and I think we should focus more on the areas of opportunity and how some potential solutions to improve the accessibility and patient-centered care for OAT. And so I want to circle back to something that Ainsley was chatting about, which is the missed doses, because that certainly is a really large barrier and hurdle for folks. And Mona, I know that you had something to speak to about that, so maybe I'll get you to.
Sure, thanks. So there is something that, just like any medications right now, opioids can be transferred, meaning if you're in a location nearby, you couldn't make it to your original pharmacy, you can ask somewhere nearby to transfer that prescription. So that actually decreases potential missed opportunities. The other thing, in British Columbia at least, pharmacists have always had like our scope actually allows us to look at different medications, including opioids, to give an extension potential right now, and also an emergency in case that individual is missing some sort of medication. So call your pharmacy. I think it's really important. And even if you leave a note earlier, that will be very helpful, because we can definitely problem solve to help the individual not miss a medication.
Thanks, Mona. Supreet?
Why don't I let Dean go?
Oh, I didn't see you.
I just want to say one thing that I think is one of the biggest things that I face now about methadone. I'm not on welfare or anything, I work, but methadone costs me over $400 a month. So everybody tells me, oh, we want you to go into treatment, Dean. We want you to get it straight. It costs me $400 a month. That's sort of weird thinking. Every other drug, it seems, for the poor is subsidized or whatever. That's a fairly, it's because then you have to, remember, most people are witnessed daily. So they have that $9 application every, for the pharmacist having to go to work every morning to fill that thing. Whereas now that I'm Carrie's, it's a little cheaper, but it's still expensive. And I think that's a huge, huge barrier. And again, I think when all these barriers come down to one thing: how is the doctor-patient relationship? If the doctor is truly wanting to deal with addicts and wants to be a methadone, because now I know they have to come through the BCCSU to be trained now, it's changing a lot more for the better. They just can't go in it because at one point it was kind of lucrative. They could just march 100 people through and put every one of them through for a urine sample every shot. They were making money. But there are many now that are there because they're interested in addiction medicines and they want to help. And typically, I think now that doctors who actually go through that training to be able to become a methadone doctor, they want to help people. Doctors aren't there to hurt people. So we've just got to get them over their own baggage and stigma that they get from their education, and balance it with trying to remove the stigma around population. And we're going to get better and better I've seen so much more advances in that than an actual legalization and drug policy. The relationship between patients and doctors is coming, and pharmacists has come a long, long way. And we're improving daily. It's one of the few parts I'm optimistic about this whole issue. So take it away, Supreet.
Supreet, did you still have something to speak to that? Otherwise, I'll turn it over to Mona.
I forgot what I was going to say, so I'm on.
Okay. Mona,
Okay, yeah, it's important. Like things have moved, like what Dean said, relationships have moved. Costs of medications actually have moved too. In BC, at least, we're very lucky. Methadone is covered. The government put everything under mental health with the Cadian I mentioned, the Suboxone I mentioned, and other medications. So the most important thing, just like any medications, if cost is an issue, talk to your pharmacist, because we'll figure out a way to address a lot of the issues surrounding some costs overall. But things have moved along, which is amazing for our province, at least.
Thanks, Mona. Okay, in the last 2 minutes here, I'm hoping just to touch on some of the other barriers. Dean, I know you mentioned earlier about, and also Supreet, around rural and remote communities and what that looks like and how it differs. And so does anything come to mind in terms of maybe less so the barriers, but some of the innovations that you've seen or we should be looking towards to help bridge that gap? Yeah, Supreet, go ahead.
Yeah, I mean, when you think about rural communities, one advantage that there certainly is that there's often a better relationship or a closer network of people who are engaged in the healthcare of that community. And so I think in that sense, you have a lot more ownership of the individuals who are in those settings. I think the difficulty becomes that if that access in terms of a prescriber or access in terms of those formal non-pharmacological supports doesn't exist, then it sort of needs to be spearheaded and established by someone who's invested in that community, which is really, I think, sometimes hit or miss. You have communities that have great supports and people who are sort of giving back to that community, and others that are much more isolated. One thing we've seen during COVID is sort of obviously a shift in medicine in general, is a shift towards virtual care or telemedicine. And I think that's had a really important benefit that we're hopefully starting to see in how care is delivered for substance use disorders across larger sort of networks or larger geographical areas. So at St. Paul's, we started recently a clinic that is doing virtual care on the Sunshine Coast and the Sea to Sky Highway, because we know we have supports in terms of pharmacies, and we know we have supports in terms of the actual medications and potentially even sort of counselors and non-pharmacological treatments there, but prescribers unfortunately are sort of a limiting factor there and in some of those regions. So I think hopefully we'll see a continued situation that mimics our neighbors to east and in Alberta, where they have a provincial network of virtual substance use disorder care that allows for people in areas where they typically wouldn't be able to get addiction care to be able to access in their communities. I think a really sad thing we see often is people locating or changing locations to a different place in order to receive medical care. We see that not just in substance use, larger urban geographical centers tend to be ones where specialist care is located, and unfortunately addiction medicine tends to be viewed as a specialist sort of procedure, even though it shouldn't be. And so it's important when we think about the complexity of how people are using substances and how important that a person's community is in their recovery, that we try to situate and provide that care where people are, not having them move to get it.
Thanks, Supreet. Okay, I'm just looking at the time. I want to make sure there's time for questions. So I'm just going to take a look at the chat here. So there's a question about whether somebody could speak to the non-pharmacological treatments for OUD and their effectiveness. Who wants to take that one?
I tried, and I think the person asked a very similar question. I put it in the answered ones. As I said, as we kind of talked about, it really depends on the person. I personally use a lot of motivational interviewing that has been shown to be quite effective with many different areas, but specifically in substance use. And really that, as we keep coming back to that rapport and relationship building, it really is about relationships. I think there's such people who have struggled with substance use and, in this case, opioid use disorder, have not had a lot of good experiences with the healthcare system. And if we can cultivate a trusting relationship, then we can encourage people to keep coming back, and we can keep that relationship going and treatment plan going. And then, as I also mentioned here, a lot of folks, opioid use isn't necessarily their number one thing that they're working on. It's food security, it's housing. Oh my God, it's poverty. It could be interpersonal violence. It could be around child welfare. It is so many other things. So it's really just meeting people where they're at. Some folks either love or hate 12-step meetings. There's a lot of different views on that, and different recovery groups. Some people go to residential treatment. And then I think we also just have to realize and stay really grounded in that, is that substance use disorder is a chronically relapsing condition, right? So I don't think we necessarily need to be so disappointed and sad if someone has had a slip or a relapse. That is, probably bound to happen, more likely than not. So just those are some thoughts for that.
Thanks, Ainsley. Any other questions? This has been so great. Thank you so much, everyone. Panelists, any last thoughts too that maybe you didn't get to share earlier? Speak now or forever hold your, yeah.
I think to Ainsley's point, the same thing, when you have students with you or individuals working, your coworkers, it's important to always check in because yes, a person's been on it for a while, it's a chronic disease. Check in always to see how that individual is still doing so that in case there's questions to keep that open communication. I think that's so important.
For those who are about to go into the service provision, get to know us. We're not monsters. We're not scary people. We're just normal people that have been stigmatized and criminalized for a very, very long time. And most of us, this isn't a party down here, guys. This is 24/7 horrible living. It's a shitty life. We don't get high down here. It's just horrible. I don't know how to even describe it, but I'm just saying that get to know us. Deal with us individually, as they say, and Supreek's backed me up to this. It's as individual as we are. I know there's only certain applications to this, but listen to us and let's try to work together on getting either partway out, at least getting healthy while I use drugs. There's a lot of end results that are very good. They don't have to mean total sobriety. There's all kinds of good outcomes without total sobriety. So just remember that and get to know us.
Thanks, Dean. Thank you so much, everyone, to all the panelists for taking some time out of your day and sharing all your knowledge and experience. We really appreciate it. And with that, Liz, I will turn it over to you. Oh, it's still me? Yes, this is still me. Okay. All right, I'm putting a little plug here. CRISM is hosting a webinar next week on December 1st, same time, from noon to 1. And this session kind of builds off of what we've been discussing today. So if you want to learn more specifically around expanding the flexibility of care, we talked a little bit today about some of the barriers around, missed doses, having to go every single day to the pharmacy. So if you want to hear a little bit more about that and how we can expand the flexibility of care for folks with opioid use disorder in BC, please tune in. We have a great list of panelists. Mona is going to be joining us again. Just to talk about where we can go from here. And this is clinician focused, but of course open to everyone with the interest and the passion. So just wanted to plug that there. The registration information is in the chat. Yeah, and that's it. Thank you so much, everyone.
Thanks, Lizzie. And thank you so much again to all of our amazing panelists for sharing your expertise. That was such a great conversation. I hope everyone found that as informative as I did. I think there's definitely tons of pearls that folks can take back to their clinical practice and teaching and just personal lives. If you want to learn more about opioid use disorder or substance use care in general, we'll put a link in the chat for 2 brand new resources documents we've developed in partnership with UBC Health and BCCSU that highlight a lot of great education and training resources. If you want to stay updated on events like this and other new resources, you can sign up for our special interest group newsletter, also in the chat. And lastly, your feedback is really important to us. So please, again, if you can, take 2 minutes to fill out our post-webinar survey. Thank you so much for joining today, and we will see you next time.